The reason for that discussion of venous return is venous return represents vascular function. And steady state cardiac output is not just about the heart. Yeah, we discussed ventricular function in section 4. But cardiac output in the body, in vivo, is ultimately influenced by both ventricular function and vascular function. And venous return and its regulation represents vascular function. So steady state cardiac output is this interplay between ventricular function and the regulation of venous return, which is vascular function. All right, ultimately there are 4 factors that are going to determine cardiac output. These are, number 1, heart rate, 2, contractility, 3, afterload, 4, preload. Did you tip your cap to the ventricle for keeping you alive? Recurring theme, contractility, afterload, preload. Contractility, afterload, preload. But the 4th player determining cardiac output is heart rate. And hopefully that makes sense, as we will see on the next slide. Okay, now what we're going to discuss are these 4 factors that determine cardiac output and how they work. Cardiac output is heart rate times stroke volume. So it makes sense that heart rate is going to impact cardiac output because it's one of the 2 factors determining cardiac output. All right. In general, heart rate and cardiac output are directly related. Just look at the mathematics. However, you would think this is very straightforward. However, it's not so straightforward because the effects of heart rate on cardiac output, all right, this effect of changes in heart rate on cardiac output is complicated because we do have to consider stroke volume. By increasing heart rate, we're reducing filling time for the ventricle. Remember, the ventricle does 2 things in diastole. It depressurizes and refills. Well, as I increase heart rate, I'm impinging on that ability to refill. And if the heart can't refill, then we're going to reduce output. Stroke volume will fall. That's Frank Starling again. That's Frank Starling. Now, the ultimate effect of heart rate on cardiac output will depend upon the cause driving up the heart rate. So let's discuss that idea. 2 big basic concepts of driving up heart rate. The first is we can increase heart rate endogenously, okay? Physiologically drive up heart rate, involving the sympathetics. Perfect example is exercise. And in exercise, heart rate goes up and cardiac output goes up with it. We are able to maintain stroke volume. Even though filling time is reduced, we're going to have a variety of changes that occur that prevent the stroke volume from falling. These include, remember, sympathetic stimulation to the heart not only increases heart rate, but it also increases the inotropic state. So it increases contractility. That helps us maintain stroke volume. Second, sympathetics, hopefully we remember, reduce the duration of the action potential. So this reduces systolic interval, contracts faster and relaxes faster. This helps preserve some of that diastolic filling time. In addition, sympathetic stimulation, hopefully you recall, increases conduction velocity in the heart. So we'll increase that rate of transmission of the electrical signal. In addition, sympathetic stimulation venoconstricts. By venoconstricting, I'm increasing venous return. This helps maintain or preserve ventricular filling. And finally, in exercise, we're engaging the muscle pump, which also increases venous return, thereby helping us maintain ventricular filling. So, the big point here is, if I endogenously drive up heart rate, that means, endogenously means the sympathetics are driving up heart rate. Well, we also have a variety of other things going on related to that that helps maintain ventricular filling and maintain stroke volume. So heart rate can go up to a considerably high level and stroke volume is still maintained. It's not impinged upon, even though we have reduced filling time. All right, contrast this with pathology. If I have a pathologic tachycardia, for example, tachyarrhythmias like ventricular tachycardia, this sudden increase in heart rate curtails ventricular filling, resulting in a drop in cardiac output. This fall in cardiac output does decrease mean arterial pressure and it activates the sympathetic nervous system, but remember, this occurs after the fact. In other words, we went into tachycardia, we didn't have adequate time for filling. Yeah, we turn on sympathetics, but it's a little bit late now. We've already reduced filling time significantly, and so we can't really compensate. Also, there is no muscle pump involved here. If someone develops V-tach, most likely position is going to be the supine position because they're going to get a syncope event, or at least they're going to sit down. They're certainly not engaging the muscle pump. So if I get a pathologically mediated tachycardia, then stroke volume will not be maintained. We will not be able to maintain stroke volume. There's just not adequate filling time, and as a result, even though heart rate is high, cardiac output falls because stroke volume falls. We'll look at that graphically on the next slide. So here's figure 5.1.11 showing us the effect of tachyarrhythmias, the increase in heart rate associated with tachyarrhythmias on cardiac output. Again, the heart's beating so fast it doesn't have time for filling, and it was a pathologic increase in heart rate. So stroke volume cannot be maintained at very high heart rates, and thus cardiac output falls. As we discussed with exercise, we could add a line here. Here is the effect of heart rate on cardiac output with exercise, because we have all these other effects going on that help maintain stroke volume. And sympathetics are driving it up. That's the initial effect. Yes, sympathetics are activated once blood pressure falls in the tachyarrhythmias, but again, that's after the fact. With exercise, it's before the fact. So when we drive up heart rate physiologically using the sympathetics, you maintain stroke volume, and as a result, an increase in heart rate increases cardiac output. If it's a pathologic increase, inadequate filling time takes over and it dominates, and as a result, stroke volume falls and thus cardiac output falls. All right, that was heart rate. What would seemingly be a very simple relationship, as you saw, is a lot more complex because it depends on what drives up the heart rate. Contractility, on the other hand, pretty straightforward. There's a direct relationship between cardiac output and contractility. If I increase contractility, I increase cardiac output. Decrease contractility, decrease cardiac output. All other factors being equal. Third player is afterload. Remember, the best marker of that is TPR. There's an inverse relationship between afterload and ventricular output. So there's an inverse relationship between afterload and cardiac output. So if afterload goes up, all other factors being equal, cardiac output's going to fall. If afterload goes down, all other factors being equal, then cardiac output goes up. Now, how do I know these things about contractility and afterload? Well, let's look at the next slide to remind ourselves. We know this relationship because of what we discussed in section 4. Ventricular function curves. Yes, absolutely. Ventricular function curves are Frank-Starling curves, and we can shift that curve up. Notice that the x-axis is stroke volume. If contractility goes up, then the curve shifts up. So there's a direct relationship between contractility and cardiac output. If contractility falls, the curve shifts down. And so stroke volume falls, thus cardiac output falls. Remember, we can put cardiac output on the y-axis. Doesn't have to be stroke volume. Afterload also affects the curve. Remember, when I decrease afterload, I shift the curve up and to the left, increasing output. If I increase afterload, I decrease the output because I'm shifting the curve down and to the right. So we knew this from ventricular function. And of course, ventricular function is a player in cardiac output. It's not the only player, though. Yeah, we need to bring in that venous return again. Venous return. Cardiac output is the interplay between ventricular function, illustrated here, and vascular function, defined by venous return. Our fourth player, okay, as we indicated, heart rate, contractility, afterload, and preload, is, of course, preload. This is Frank Starling. Assuming no change in afterload or contractility, in other words, all variables being equal, if I increase preload, cardiac output goes up. There's a direct relationship, right? Give the heart more blood, it pumps more blood. Give it less, it pumps less. That's Frank Starling. But the key, what determines preload? Venous return. Venous return determines our preload. That's why we have to take that into consideration. And again, venous return represents function of the vasculature. All right, let's discuss the idea of right atrial pressure now and its impact on venous return and on cardiac output. All right, right atrial pressure is the downstream pressure for venous return. So if right atrial pressure goes up, hopefully you say, okay, well then that means venous return goes down. Has to be. It's the downstream pressure. So if right atrial pressure goes up, venous return falls. So right atrial pressure is impacting venous return. It also impacts ventricular function, but it simultaneously impacts venous return. Let me ask you this. What would happen to venous return if right atrial pressure became equal to mean systemic filling pressure? Hopefully you said venous return would go to 0, because if PSF and right atrial pressure are the same, there's no pressure gradient, therefore there is no flow. So no venous return. So to recap, right atrial pressure, that's the x-axis on a ventricular function curve. It has a positive impact on ventricular function, but it has a negative impact on venous return. And steady-state cardiac output, therefore, is the interplay between ventricular function and vascular function. And right atrial pressure has an opposite effect on the two. It enhances ventricular function, but it decreases vascular function. That's the big key. All right, this graph puts them together. This is called a cardiac output venous return curve. First of all, pay attention to the axes. X-axis is right atrial pressure. The y-axis is cardiac output / venous return. All right, now, what is this graph telling us? Well, this graph is telling us that steady-state cardiac output is influenced. It's the interplay between ventricular function and vascular function. And again, venous return curves are defining vascular function for us. All right, the solid line moving up and to the right is ventricular function. We've seen ventricular function curves in section 4. We reminded you of ventricular function curve just a few slides ago. So that's ventricular function. And if I increase right atrial pressure, I increase ventricular function. That's a Frank Starling curve. Now, contrast that, as we just went through on the previous slide. Right atrial pressure has a negative impact on venous return. And we said when mean systemic filling pressure and right atrial pressure are equal, venous return is 0. So notice the dashed purple line. The dashed purple line hits the x-axis. Where it hits the x-axis means there's no venous return. Well, why would there be no venous return? because that means PSF and right atrial pressure are equal. So wherever the dotted line hits the x-axis, that x-intercept for the venous return curve, that is mean systemic filling pressure. Now, if you have to stop the video to let that soak in, please do so. I'll repeat again. Where the venous return curve hits the x-axis, in other words, the x-intercept, that means there's no venous return. That is a right atrial pressure in which there is no venous return, which is mean systemic filling pressure. It means those two pressures are the same. Now notice how the curve is different for vascular function. We're going the opposite direction from ventricular function. Remember, as right atrial pressure falls, then venous return goes up. That's what the dotted purple line shows. That as right atrial pressure is falling, venous return is going up, which makes sense because remember, right atrial pressure is the downstream pressure. So as downstream pressure is falling, assuming no change in PSF, then venous return goes up. Now here's the key. Here's the other big key to this graph. Point A, notice that is where ventricular function and vascular function intersect. So point A on this graph is always steady state cardiac output. The ventricular function line is not cardiac output per se. It is ventricular function. And ventricular function, that's how the heart works. And vascular function, where they come together, where they intersect, is steady state cardiac output. So steady state cardiac output is always that point where the two lines intersect. That is cardiac output. Not the solid line per se, but a specific point on that solid line. Notice, venous return determines preload. Venous return is determining where the heart is with respect to ventricular function. In other words, where it is on the ventricular function curve. All right? So, once again, A represents steady state cardiac output. It's the interplay between ventricular function and vascular function. Yes, I've stated it many times, written it a couple of times, because that's what these curves are showing us. For the math magicians in the group, we are solving two equations simultaneously. If that helps you, awesome. If that doesn't help you, then don't worry about it. You don't have to do the mathematics. But for some people, hopefully that'll just kind of bing, the light bulb goes off. And I love light bulbs. All right? So again, the purple line is not cardiac output. That point on the purple line, where the venous return curve intersects it, that's cardiac output, because venous return determines preload. Venous return determines preload. All right, let's work with understanding the regulation of cardiac output. We'll do it first in words, then we'll go back to the graph. And then words again, and then back to the graph. Okay, and hopefully by the end, when we've thought our way through this, we're just applying pressure, flow, resistance, pressure, volume, compliance. We're just applying those basic concepts. But we're building up to this magnificent regulation of cardiac output. Oh, it's so cool. Physiology is so cool. And hopefully at the end of this, you'll be going, yes, regulation cardiac output. I got it. I own it. I own it. I can do anything with it now. Step one, clinically, everything. It's all great. All right, let's start with resistance. Remember, arterioles are the main site of resistance. If arterioles vasodilate, that means resistance goes down, then venous return goes up. Hopefully that makes sense. Remember, venous return is the flow, so if resistance falls, flow goes up. We've discussed that previously. Vasodilation also decreases afterload. Remember, if I dilate arterioles, that means reduce TPR, that decreases afterload and shifts the ventricular function curve up and to the left. All right, we reviewed that briefly just a little bit ago, but again, that is section 4. So arteriolar vasodilation enhances both ventricular and vascular function. Going the other way, if the arterioles vasoconstrict, that means increased resistance, so flow falls, venous return falls. So vasoconstriction reduces venous return and steady state cardiac output will fall. And as we'll talk about and as we'll show you, it's because we're moving down the Frank-Starling curve. Because remember, venous return determines preload. Vasoconstriction means increased resistance, increased TPR, so therefore increased afterload, which will shift the ventricular function curve down and to the right. So arteriolar vasoconstriction, as you would predict since vasodilation did the same thing, affects both ventricular and vascular function, and it reduces both of them. All right, let's look at it graphically. Here are three different curves. Okay, the black dot represents steady state cardiac output. That's where we start on that point. Again, as we described, venous return determines preload. Now, A represents arteriolar dilation. All right, arteriolar dilation. Notice, we moved up the Frank-Starling curve. What happened to steady state cardiac output? Hopefully you said, it went up. Does it make sense to you that if I reduce resistance, I'll get a greater venous return, and as a result, I get a greater venous return, that means cardiac output's going to go up. Hopefully that makes good sense. B represents the opposite, arteriolar vasoconstriction. What happened to steady state cardiac output? It went down. Excellent. So by vasoconstricting arterioles, I reduce venous return, I come down the Frank-Starling curve. So as you can see, we're moving up and moving down the Frank-Starling curve. Now I want you to notice something else about these curves. Notice that they all start at the same x-intercept. All right, let's review again. X-intercept. That is the right atrial pressure in which there's no venous return. So in other words, the x-intercept is PSF. Now, we haven't changed PSF. That's what these graphs are saying. Well, that should follow. Because remember, PSF is determined directly by blood volume, inversely by venous compliance. Well, I'm just constricting or dilating arterioles only. So I'm not affecting total blood volume. And since I'm not affecting the veins, I'm not affecting venous compliance. So that's the reason PSF doesn't change. All right, how are we going to remember this? Let's think about it. One way that you might like is the following. If I vasodilate, I'm going to put more blood in the heart. In other words, put more blood in the tank. Think of a car runs on gas. Well, output from the heart is dependent upon blood getting in there, so the tank. So notice, curve A, a shift up in the venous return curve. I vasodilated, so I put more in the tank. So vasodilation moves me up the Frank-Starling curve. Vasoconstriction, on the other hand, reduces how much I have in the tank. I can't get the blood back to the heart. So I come down the Frank-Starling curve. So notice that I have a reduction in steady state cardiac output in part because I have less available in the tank. Now, if that way works for you, excellent. How do I remember this? Well, I look at the slopes of the line. The slope of the line, the venous return curve, is a flow over pressure. Well, that's the inverse of resistance. So the slope of the line is the inverse of resistance. So in other words, if the slope goes up, that means resistance went down. If the slope goes down, that means resistance goes up. So I just think of the slope of the line and know that it's the inverse of resistance, which we can also call conductance, because remember, the inverse of resistance is conductance. That's how it works for me. Again, use the methods that work for you. More or less in the tank, if you want to think about it that way, or think of the slope of the line as being 1 over resistance, or the inverse of resistance. Either way, you're going to get to the right answer. All right, now don't forget that changing arterials changes afterload. So when I vasodilate, not only do I put more in the tank, but I also enhance ventricular function. So notice the rise in steady state cardiac output. So it increases both venous return, vascular function, and ventricular function. And that's what we described on the previous slides. Vasoconstriction, on the other hand, decreases ventricular function. So it would move down. Ventricular function curve shifts down. So vasoconstriction decreases both venous return, vascular function, and ventricular function. So we're just applying. So always try to start from the very fundamental and just apply the concept. All right? Apply the concepts. We know that arteriolar dilation will put more in the tank and that it reduces afterload, so it enhances ventricular function. So I just go step by step. Hopefully that can help you when working with these curves. All right, let's think about these curves and changing PSF. As we indicated, PSF is directly related to blood volume and inversely related to venous compliance. It is a pressure when there is no flow. So if I increase vascular volume, how can we do that? How might it show up on step 1? Give somebody an infusion of volume. We could activate our RAS system, more on that in the endocrine section and renal sections. Or we could decrease venous compliance. How do we do that? Sympathetic stimulation, muscle pump, exercise, lying down, as we will discuss when we talk about gravity. So increasing vascular volume or decreasing venous compliance increases PSF. This is going to cause a full right shift in the venous return curve. And again, we'll show you that picture in just a moment. Either of these changes increase venous return, therefore they enhance the filling of the ventricle. So you move up the Frank-Starling curve and cardiac output goes up. C represents an example of what we just discussed. So again, the black dot represents normal. That's our steady state. C shows that PSF went up. First thing you should notice about line C is PSF went up. What causes PSF to go up? Well, either an increase in vascular volume or a decrease in venous compliance, or both. Notice we put more in the tank. We moved up the Frank-Starling curve. Now we're not changing the slope here because we're not changing resistance. We're either adding vascular volume or decreasing venous compliance. Remember, the resistance across the veins is negligible. So any venoconstriction is not going to appreciably influence resistance, so we can ignore it. But the big point is it increases PSF, which increases venous return, which moves us up the Frank-Starling curve. Now, remember, where the curves intersect is steady state cardiac output. It's also steady state right atrial pressure. Notice that curve C, we have a higher steady state preload, a higher steady state right atrial pressure. Please stop, look at the graph. And again, hopefully it makes sense. We have a higher cardiac output. We moved up the Frank-Starling curve because we increased preload. And we increase preload because we increase venous return. Venous return determines preload. All right, now let's go the other way. Let's decrease PSF. How do we do that? Decreasing vascular volume. Like with hemorrhage, burn trauma. Remember, in burn trauma, we're going to lose volume in the vasculature. That plasma just leaks out. Vomiting, diarrhea. We can also increase venous compliance to decrease PSF. As we discussed, This is inhibiting sympathetics, alpha block, venodilators. Again, venodilators are going to have a bigger effect in general than alpha blockers. And again, standing upright. All of this decreases PSF and will cause a left shift in the venous return curve. Either of these changes will reduce filling, Frank-Starling. We're going to come down the Frank-Starling curve, and as a result, reduce cardiac output. We'll look at it graphically on the next slide. Okay, again, we're working with the curve on the right. D represents a decrease in vascular volume or an increase in venous compliance. As we did with C, what you should notice immediately is this change shows a decrease in PSF. Because remember, PSF is the x-intercept for the venous return curve. So PSF went down. That should be your first thought. You get a picture like this and you see this shift, you say, okay, PSF went down. Well, what would cause PSF to go down? Well, that would be either a decrease in vascular volume or an increase in venous compliance or both. So that's the first thing you should note. Now, as you can see, we put less in the tank. By reducing PSF, we reduce venous return. We come down the Frank-Starling curve. All right? We move to a lower point on the Frank-Starling curve. So steady state cardiac output, again, that is the intersection of the two lines. Steady state cardiac output has gone down. Now notice, steady state right atrial pressure is less. Oh, again, hopefully that makes good sense. That clinical variable that you're measuring, right atrial pressure. Well, if someone's hemorrhaging, they're losing blood, then right atrial pressure is going to be low. That tells us that. Low vascular volume, or an inadequate venous return due to a big increase in venous compliance. Most likely scenario, clinically, is losing blood volume. But if we had a marked venodilation, we would also see a drop in right atrial pressure. So hopefully it makes good sense. We have less in the tank. Our clinical measure of a lower right atrial pressure is really, that's one of your first thoughts. A low right atrial pressure, you're thinking, man, there's a low vascular volume. Second thought is, oh, maybe I got a lot of venodilation going on here. Maybe something happened to their sympathetics. Maybe they took a drug, a venodilator, too much of a venodilator. So hopefully this all comes together and you go, woohoo, cardiac output. It's regulation. I got it. I got it. Cardiac output venous return curves. So cool. It's so cool. You own cardiac output regulation now. You can deal with any kind of question on the step exam. And you know what? You can apply it when you get to the clinics. It'll all work. It'll all work. It's awesome. It's physiology.